So they probably didn't need the drug. So we started thinking about ways that we could figure out who to target to actually get the drug, because not everybody needs it. Okay, so that's how clinical trials start out. You treat everybody, and then when you see the effect, you then try to narrow down, okay, who's really getting the benefit from the drug. So we created this nomogram, and if you Google MSKCC just nomogram, you'll find an electronic version of this. So patients all around the world can access this, and they can actually figure out, and this is an estimate, it's a mathematical model, they can figure out what their likelihood of recurrence is. And based on that, that might help us decide whether they should take adjuvant postoperative imatinib. So this is just one example. This is a patient with a 5-centimeter tumor, and you just read up for each of the 3 features, and you get a point for each, a series of points for each one. You add all the points together, and you read down here. So these are mathematical models that are very easy to read. And for this particular patient with a 5-centimeter tumor with a high mitotic rate from the stomach, you can see they have about a 50% chance of recurrence, even at 2 years after the surgery. So this is somebody that we would give adjuvant imatinib to. We validated this. We created it with the Memorial data, and then we validated it in the Sarcoma Registry of Spain, and also one at the Mayo Clinic. So it seems like a pretty robust tool. So we use this all the time now in the clinic. This is the ACOSOG data, the Z9001 trial. And there's a pathologist named Mietnin who created a different risk score well before our nomogram. And we applied his risk score in this particular presentation, which was at ASCO last year. And what we found, which was not that surprising, was about half the patients that entered our trial were actually very low risk based on what we know now, not necessarily based on what we knew when they entered the trial. So what you can see here is at 2 years, the recurrence-free survival is the same. Almost nobody in this group developed a recurrence. So based on this, someone who walks in the door now who falls into this low-risk category, we don't actually recommend postoperative therapy. Whereas the patients at moderate risk, now there's a big difference. 2% of the people in the imatinib arm have recurred if they took imatinib, whereas 24% if they were on placebo. So many of these patients we still recommend for adjuvant therapy. And then the high-risk group, there's obviously a big difference here. But the key is that half the people that walk in the door now, we just tell them we don't think you actually need the drug. So we took it one step deeper, and this is work Christina did sequencing, as well as Chris Corliss helped out at the end. And we can break it down now by actually type of mutation. So the most common mutation, as you probably know, is exon 11, and big difference between the placebo arm and the imatinib arm. Okay, most of these patients did extremely well, and again, I've shaded the area where they actually got treatment. So exon 11, definitely we recommend it if you have some of these other moderate to high-risk features. This was kind of an interesting outcome because it was not predictable based on what we know in the metastatic setting. We think the drug is somewhat beneficial, even if it just causes the tumor to go to sleep for a while in the metastatic setting. But strikingly, in our patients who are wild type, and we have to do a little more investigation of these patients, but there's no difference in how they did, whether they got the drug or not after their surgery. And exon 9 is a little confusing. There's not a lot of patients, but it looks like at least while they were on the drug, the blue line here, the patients were protected. When they stopped the drug, then they had this sort of the same outcome as those who never got the drug. So again, this is with our 1.5 year follow-up. We should now have over 2 or 3 times that, so our next analysis will be even more meaningful.
So what I'm going to do is just briefly talk about some of our current directions in terms of clinical trials with this. There's a lot of work that needs to be done clinically. Our current efforts are kind of twofold. One, as Ron said, although we have some very effective drugs for this disease, the efficacy doesn't last forever. And so one of our goals is to try to identify newer, perhaps more effective tyrosine kinase inhibitors. And I'll talk about one of our studies to do that. And the second is work really based completely on Ron's data that he just presented improve the efficacy of current tyrosine kinase inhibitors by kind of harnessing the immune system and see if we get more prolonged responses, more durable responses. The first study that I want to talk about is a phase 3 study of regorafenib. And as you know, this disease, there are a lot of IBs, and there are a lot of new tyrosine kinase inhibitors that are being studied, like latinib and masitinib, nilotinib, and so forth. This is another drug which is being developed by Bayer that targets a whole number of tyrosine kinases in terms of just, obviously, it's targeting KIT and PDGFR alpha. It also affects angiogenesis pretty heavily. So it hits a lot of targets that are important for blood vessel production. So it hits all of our, what we call our VEGFR receptors, vascular endothelial growth factor receptor, and PDGFR alpha and beta, and another thing that's important for blood vessel production, FGF, or fibroblast growth factor, and something called Tie2, and also hits some other targets as well. This, as you would expect, is effective against mutant GIST, and so this is just some cell line data. And here, what I'm showing is just the efficacy in inhibiting the KIT kinase in this cell line called GIST882, which has this particular mutation, the K642B mutation. And basically, you know, the lower this number, the better. This is just what concentration of drug you need to cut the kinase activity in half. And so this is quite low. And it also suppresses the GIST cell line proliferation as well, suggesting that this might be a potentially effective drug. Another thing that this drug can do is it can also inhibit the KIT mutations that connote resistance to imatinib. And so Christina's done a lot of work in this one model, the BAF3 model, where she can introduce specific KIT mutations into the cell line and test to see if different drugs work. The same sort of work has been done with this drug, regorafenib. And what you can see is that, again, these IC50s, the concentration of drug that you need is quite low in these double mutant cell lines. These are the cell lines that have an exon 11 deletion, as well as these various other secondary mutations, some of which connote really strong resistance to Gleevec and other drugs. And so here in the T670I mutant, you can see the IC50s, 19 nanomolar, certainly much lower than Gleevec here, and with an N822K mutation, it's 12 as opposed to 221. So again, in some mutations, this drug may be better than Gleevec and perhaps even Sutent. This drug's completed phase 1 clinical trials and is currently being investigated in a couple other diseases as well. In the phase 1 studies, you want to identify a safe and tolerable dose, and so they've done continuous dosing of this oral agent where you take it orally every day, as well as what they call intermittent dosing, where their patients are taking it for 21 days in a row and 7 days off. And they're studying it in renal cell and hepatocellular and colorectal, and of course in GIST. The GIST study is being led in Boston. I don't have a more recent update than this, but this is the phase 2 study results as of last year, so this was just partial results. And basically on this study, they enrolled patients with advanced GIST who've either progressed or were intolerant to imatinib and who progressed on sunitinib. So these are kind of third-line patients. And all of the patients got regorafenib 160 milligrams daily, 3 weeks on, 1 week off. And the primary endpoint for this study is clinical benefit. Certainly a response is good, but prolonged disease stability is also okay in this disease. And at this point, 19 of the planned 34 were enrolled, and 17 of 19 remain on study as of this time. If you look at the patients who are still on, 3 of them were on study for 6 months or longer, which is quite good, and the remainder of the 17 were on just for shorter periods of time, and they did see a partial response at that point. So in part based on that preclinical and clinical data, there is this international phase 3 trial of this drug, regorafenib, versus placebo in patients who've either progressed or were intolerant to Gleevec and progressed with Sutent. They can receive other tyrosine kinase inhibitors or other treatments as long as it didn't target VEGFR. So most of the patients, or at least 50% of